All right, so a very good evening, everyone. So this will be a quick revision on the infectious diseases. I'll try to cover mainly the very important infections which will be expected in your upcoming NEET PG exam. Okay, so I am myself Dr. Rajesh Gubba. I am the general medicine educator. So just give me a minute. Just 1 second. Okay, so just give me a quick thumbs up. Like, am I audible and visible to all of you? Yes. Right, so thank you very much, humanity first. Okay, so now after having discussed about the entire session related to infectious diseases, I'll be posting this PDF on my Telegram channel, right? And my Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba. Okay, so in this Telegram channel, you can download the PDF with annotations. Okay, right. Having said this, let us start. So I will discuss all the questions with the form of a question. Okay, in the form of a question. Now, what is the drug of choice for scrub typhus? Erythromycin, doxycycline, ciprofloxacin, linezolid. And I'll give you complete details about the scrub typhus. Okay, so anyone want to make an attempt of this quick question? So what is the drug of choice for scrub typhus? Very good, Kavya. So the drug of choice for the scrub typhus is your doxycycline. Now, what are the important images related to scrub typhus? So first of all, you need to know what is the organism causing this scrub typhus. So the organism that is causing scrub typhus, that will be Orientia susugamushi, right? The organism causing scrub typhus is Orientia susugamushi, and this is a parasite of rodents, and it is transmitted by larval trombiculid mites. So this is the organism that will be causing scrub typhus, and how it is being transmitted? It is being transmitted by chiggers. Okay, it is transmitted by chiggers. What are these chiggers? These are larval trombiculid mites. Okay, now what will be the presentation in the individual? Now at the point wherever there is a bite, there will be formation of an eschar. So this black dot, whatever you are seeing here, it's an eschar. Now along with this eschar, the individual with scrub typhus, they will have high fever, right? The other manifestation is a high fever, and the headache can be there. Apart from this, in Salmonella typhi, can anyone tell me how will be the heart rate in patients with Salmonella typhi? In patients with Salmonella typhi, that is in typhoid, you get what is called relative bradycardia. Similarly, even in case of the scrub typhus also, you will have the relative bradycardia, right? You will have relative bradycardia. Now, what is the skin manifestations? The skin manifestations in patients with the scrub typhus, we call it as macular rash, right? We call this as the macular rash. Okay, so this will be the skin manifestation in patients with the scrub typhus. Next, you need to know what are the complications in patients with the scrub typhus. So the complications that you come across in scrub typhus, there can be development of pneumonitis, right, where there can be involvement of the lung. Next, there will be also involvement of the brain, that is in the form of encephalitis, and there is also involvement of the heart, that is in the form of myocarditis. So these are the important clinical features of the scrub typhus. Now you need to know, like, how will you diagnose this particular scrub typhus? What is a gold standard investigation? Now, can anyone tell me what is a gold standard investigation for the scrub typhus? The gold standard investigation for the scrub typhus, it is indirect immunofluorescent assay and indirect immunoperoxidase assay. These are the gold standard investigations. Right, these are the gold standard investigations. Now, what is the drug of choice for scrub typhus? Just now we have discussed, that is doxycycline is the drug of choice, right? So what is the dosage of this doxycycline? You have to give 100 milligrams twice daily for 2 weeks. So either doxycycline or the other alternative drug is minocycline. The other alternative drug is minocycline. So these are the important points about the scrub typhus. So I'll quickly revise scrub typhus. Scrub typhus, the organism is Orientia susugamushi. The parasite, that is an organism, I'm sorry. And it is transmitted by larval trombiculid mites, which is nothing but chiggers. And the clinical manifestations are high-grade fever and headache. They will have relative bradycardia, and at the site of bite you will have black eschar, and the skin manifestation will be in the form of macular rash. Complications include pneumonitis, encephalitis and myocarditis. And what is the gold standard investigation? Indirect immunofluorescent assay and indirect immunoperoxidase assay. And the drug of choice will be doxycycline or minocycline. Okay, doxycycline or minocycline. Okay, so that is about your points related to scrub typhus. Now we'll move on to the Zika virus. Right, Zika virus is another important area where the questions can be asked. All of the following clinical features are seen in Zika virus except, please answer this question. Yes, please answer this question. Guillain-Barré syndrome, petechial rash, fever with polyarthralgia, conjunctivitis. Right. Yes, Dr. Refarmer, what is your question? Sir, can we give doxycycline in pregnancy? Remember, when you use this doxycycline for a shorter period of time, then there is no harm in your baby. That means there will be no teratogenicity when doxycycline is used for shorter period of time. But when doxycycline is used for a longer time in pregnancy, then there is a small chance that it can affect the teeth and as well as bone development. So if you are giving for a short period of 1 week, there is no problem. But if you are giving more than 1 week, like 2 weeks, 3 weeks, 4 weeks, then it can affect the bone and as well as teeth development of the baby. So yes, Dr. Reformer, did you understand this question now? Have you got the answer? Okay, now coming to Zika virus, right? So if you take this particular Zika virus, like you should know the name of the mosquito. Can anyone tell me what is this mosquito which will transmit this particular Zika virus? I'll come to the answer. But you take the mosquito which will be transmitting this Zika virus. So please remember, it is Aedes aegypti. Right, Aedes aegypti, that is primarily responsible for the transmission of the Zika virus. Okay, now which of the following feature that is not seen in patients with Zika virus is you don't get this petechial rash. You don't get this petechial rash. In case of Zika virus, what will be the clinical manifestations? So the rash that you get in case of Zika virus is pruritic maculopapular rash. Right, pruritic maculopapular rash. And what will be the ophthalmic manifestations? The ophthalmic manifestations will be in the form of non-purulent conjunctivitis. Right, that is in the form of non-purulent conjunctivitis. So these are the manifestations that you come across in patients with the Zika virus. And not only that, they will also have arthralgia. And all these manifestations, they last for nearly around 7 days. Right, all these symptoms, they last for nearly around 7 days. Okay, and what are the neurological complications? This is very, very important in case of Zika virus. So you take the neurological complications. There are two important neurological complications. One is, you can see the head of the baby. Like, how is it? It is like very short. So What is this called? This is called as microcephaly. Right, this is what is called microcephaly. Now why do you get this microcephaly is the Zika virus can pass, vertical transmission can be there for Zika virus. There will be transplacental passage, and once there is transplacental passage, that Zika virus will cause brain calcification, right? And because of this brain calcification, the brain development will not be there, and thereby there will be microcephaly. And another important neurological manifestation will be the Guillain-Barré syndrome. So these are the two neurological manifestations with Zika virus. Then and conjunctivitis will be there. What will be that? Non-purulent conjunctivitis, and there will be fever even with polyarthralgia. Now coming to workup in case of the Zika virus, right? Coming to the workup in these patients with the Zika virus. See, you have the antibodies, that is Zika MAC ELISA IgM neutralizing antibody. Okay, so it is IgM neutralizing antibody, and this particular IgM neutralizing antibody is detectable 4 days after, right? 4 days after the symptom onset. Okay, then the other important antibody is the IgG antibody. IgG antibody to Zika virus, that will appear 7 days after the symptom onset. 7 days after the symptom onset. So this is the workup for your Zika virus. Then how do you treat these patients with Zika virus? As such, for Zika virus there is no specific treatment, okay, but for the fever what we give is paracetamol, and rest may help the symptoms of your Zika virus. Okay, now let me quickly recap the entire Zika virus. So please remember, Zika virus, it is being transmitted by Aedes aegypti, right? The manifestations will be fever with polyarthralgia, and there will be pruritic rash. What rash? Maculopapular rash, but it is not petechial rash. And the ophthalmic manifestations will be in the form of non-purulent conjunctivitis. And all these symptoms, they last for nearly around 7 days. And there are two neurological manifestations. One is microcephaly and the other one is the Guillain-Barré syndrome. And how do you do the workup of Zika? IgM antibody, which will appear 4 days after the symptom onset. IgG antibody to Zika virus 7 days after the symptom onset. And there is no specific antiviral drug, but we give only paracetamol. So this is about your Zika virus. Okay, right. So we have discussed the scrub typhus, and the next we have discussed the Zika virus. Now another very important area for the questions in infectious diseases is related to pyrexia of unknown origin. The definition of pyrexia of unknown origin includes all of the following except illness persisting for more than 3 weeks, undiagnosed fever after 1 week of inpatient workup, absence of immunocompromised state, temperature more than 38.3 degrees centigrade or more. Okay, so which of the following is not the point related to the pyrexia of unknown origin? Yes, it is not D. It is not D, reformer. Okay, now what are the latest guidelines, right? What is the latest definition of pyrexia of unknown origin? See, now this undiagnosed fever after 1 week of inpatient workup, that is the wrong statement. Okay, now according to the present guidelines, like what is the definition of pyrexia of unknown origin for hospitalized patients is undiagnosed fever in spite of 3 days of hospitalization, right? In spite of 3 days of the hospitalization, and you have done complete workup in this particular 3 days of hospitalization. That is what is the definition of the pyrexia of unknown origin. It is not 1 week. So in the recent guidelines, the guidelines have been changed to 3 days of hospitalization. So please remember, this is very important point. Okay, next, illnesses which is persisting for more than 3 weeks, it is a part of the pyrexia of unknown origin. Okay, next, and one more 3 is that diagnosis of fever not made in spite of 3 outpatients, right? 3 outpatient visits. So now you just see, now there are 3 important 3s. Number 1, illness persisting for more than 3 weeks. Number 2, diagnosis of fever not made in spite of 3 outpatient visits. Number 3, 3 days of hospitalization and complete workup done, but still we don't know what is the cause of fever. Okay, so that is also the part of pyrexia of unknown origin. An absence of immunocompromised state is a part definition of pyrexia of unknown origin. Temperature of more than 38.3 degrees centigrade or more is also the definition of the pyrexia of unknown origin. Okay, so PUO, this point is very, very important. It is not 1 week of inpatient workup. The present guidelines, 3 days of the inpatient workup, still you don't know what is the cause of fever. That we call it as pyrexia of unknown origin. Okay, so that was about your PUO definition. So we have discussed scrub typhus, we have discussed Zika virus, we have discussed the pyrexia of unknown origin. Now another very important area where the questions will be asked is about the rabies infection. Okay, that is dog bite, right? A young male is admitted with history of altered sensorium and hydrophobia. A clinical diagnosis of rabies was made and corneal scrapings were taken. Which is the best test to confirm his diagnosis? Cellular stain for Negri bodies, indirect immunofluorescence, real-time PCR, viral culture. So for this particular rabies, what is the investigation of choice? Right? So for this particular rabies, you need to know like what is the family of this particular rabies virus. The family of the rabies virus, it is nothing but your rhabdovirus. Rhabdovirus. Okay, I got correct answer only from Abhay Dev. Very good, Dr. Abhay Dev. So the correct answer here is the viral culture. Now let me explain to you why the viral culture is the answer. I'll try to explain to you. So the virus is the family of rhabdovirus, right? And it is transmitted by the infected saliva, right? It is transmitted by the infected saliva that enters the body by an animal bite or an open wound. Now, what are the classical manifestations in patients with the rabies virus infection? At the site of bite, there will be paresthesias, right? And very, very important manifestation is the hydrophobia. Very, very important manifestation is the hydrophobia. Now you should understand why there is hydrophobia in this patient. Now, can anyone explain why in patients with rabies infection they have hydrophobia? Any one of you, please? Why in patients with rabies infection they have hydrophobia? Okay, so if anyone can answer, right, that would be really great. Yes. Okay, so let me try to explain to you. Now, in these patients with rabies, like what happens is there will be pharyngeal, very good. Who's that? Iqbal Bahar. Very good, Iqbal Bahar. So basically what will happen is there will be, but it is not laryngeal spasm. You said some spasm, which is correct, Iqbal Bahar, but it is not laryngeal spasm. It is pharyngeal spasm. Okay, right. So now these patients, they will have pharyngeal muscle spasm. Okay, pharyngeal muscle spasm. Which patients? These patients with the rabies. So hydrophobia, it results from pharyngeal muscle spasms that make it difficult for rabies victim to swallow. So what I want to tell you is rabies does not necessarily cause hydrophobia, but rabies is causing this pharyngeal spasm. So the individual will have a fear and the individual will suffer from inability to swallow. That makes rabies victim avoiding drinking water and as well as the swallowing of saliva. So I hope everyone is clear regarding this. So as such, rabies does not necessarily cause hydrophobia, but rather the fear and inability to swallow makes rabies victim avoid drinking water and as well as swallowing saliva. So that is what is the reason why you will have hydrophobia. Now in patients with rabies, you also have the CNS manifestations. What will be that CNS manifestations in rabies? There can be development of the convulsions. There is also paralytic form of rabies. right? And the saliva of these individual will be a thick, tenacious saliva. Thick, tenacious saliva. Now, what about the other options in the question? Right? What about the other options in the question? You take this cellular stain for Negri bodies. See, choice A is completely ruled out. You know why? Because it is used in postmortem. Right? It is used in postmortem. It is not when the patient is alive. And what are these Negri bodies? Negri bodies are eosinophilic inclusions seen in Purkinje cells of the cerebellum. So where all you get this Negri bodies? You get this in cerebellum. Okay, and you get this in pyramidal neurons or pyramidal tracts, and you also get this in the hippocampus. So these are the sites where you can have the presence of the Negri bodies. Now, what about choice B? Choice B is also ruled out as many vaccinated individuals are positive for antibodies in the serum. So vaccinated individuals, they also can have the antibodies within the serum. So that is the reason why your indirect immunofluorescence is completely ruled out. Okay, then your real-time PCR, that is also not helpful for diagnosing the rate. Okay, but if you take this real-time PCR and as well as viral culture, right, both of them, they are very close choices. But in the textbook of infectious diseases, what is the textbook of infectious diseases? That is Manson is the standard textbook for infectious diseases. So according to this Manson textbook of tropical disease or infectious disease, what he has given is the viral culture. It is the gold standard investigation for the diagnosis of the rabies virus. Okay, you take this real-time PCR. Real-time PCR is mentioned only for saliva. It is mentioned for CSF and as well as the skin biopsy. Now, and at the same time, in these patients, you should know what is the cause of death in patients with the rabies virus infection. So there will be respiratory muscle paralysis causing respiratory failure, and that will be the cause of death in patients with the rabies virus infection. Then how do you treat these patients with rabies infection? So post-exposure immunization, right? Post-exposure immunization, you can give passive immunization or you can give active immunization. So if you take the passive immunization for your rabies, passive immunization is the human rabies immunoglobulin, right? Human rabies immunoglobulin. 20 units you have to give per kg once daily. Sorry, only once, not once daily, once. Okay, so that is passive immunization. That is human rabies immunoglobulin 20 units per kg administered once, right? What about this is passive immunization. What about the active immunization? See, for active immunization, there are two vaccines which are available, right? That is containing inactivated rabies vaccine. So what is that active immunization? One is the Imovax, which is nothing but human diploid cell vaccine, right? Human diploid cell vaccine. This is nothing available in the market in the name of Imovax. And one more is purified chick embryo cell vaccine. Okay, so these are the two important vaccines. Now, where these particular vaccines have to be administered, these vaccines, they have to be administered intramuscularly. And where you will administer, you have to administer either over the deltoid or you have to administer over the anterolateral aspect of the thigh, right? Anterolateral aspect of the thigh. Okay, now how many times you have to give this vaccine? What is the schedule? The schedule of the vaccine is on day 0, then 3, then 7, then 14. So you have to give totally 4 doses. And what about the 5th dose on 28th day? Now this 5th dose, it is no longer recommended. The 5th dose should be given only if the patient is immunocompromised. Only if the patient is immunocompromised, in them we give this 5th dose of the rabies vaccine active immunization. So this completes the discussion of your rabies story. So I'll quickly recap regarding this particular rabies story. So please remember, for rabies, the best test to confirm the diagnosis is viral culture. This rabies virus belongs to rhabdovirus family, and it is transmitted by infected saliva that enters the body by an animal bite. The features will be paresthesia, hydrophobia, convulsions, paralysis, thick tenacious saliva. And why there is the hydrophobia? That is because of pharyngeal muscle spasm. Negri bodies are not useful for the diagnosis because they are post-mortem finding, and they are nothing but inclusion bodies seen in Purkinje cells of cerebellum, then pyramidal neurons of the hippocampus. Then you take B, that is indirect immunofluorescence. That is ruled out because it will be present in vaccinated individuals, right? And what is the cause of death in patients with rabies? That is respiratory failure. Post-exposure immunization is by passive and active immunization. Passive immunization is by human rabies immunoglobulin, 20 units per kg administered once. Active immunization, you have two vaccines, that is inactivated rabies viruses are present in these two vaccines. One is human diploid cell vaccine and the other one is purified chick embryo cell vaccine, right? They are administered intramuscularly. 1 ml has to be administered either over the deltoid or into the anterolateral aspect of the thigh muscles. The schedule is 0, 3, 7 and 14 after the exposure, and the 5th dose should be given on 28th day, but it is no longer recommended except for the immunocompromised patients. So this is about the story related to the rabies infection. Okay, now we will move on to the next question. Right, 1,3 beta glucon test can be used for all of the following, right? For all of, yeah, you take this intradermal route. Yes, Agastya Gopi, you take this intradermal route. Yes, we also have the intradermal route of administration also, but the preferred route is the intramuscular. Okay, the preferred route is intramuscular, right? Yeah, so 1,3 beta glucon test can be used for all of the following infections except, right, very good, Dr. E. Farmer, and as well as Dark Knight. So the answer is the invasive cryptococcosis, right? Invasive cryptococcosis. So this current guidelines, what it says is this 1,3 beta D glucon test. It is useful for the diagnosis of a suspected deep-seated fungal infections of the aspergillosis, candidiasis, and it is also useful for the diagnosis of pneumocystis jirovecii pneumonia, but it is not useful for cryptococcosis. It is also not useful for mucor, and it is also not useful for diagnosis of rhizopus, and it is also not useful for the diagnosis of blastomyces, and it is also not useful for diagnosis of cryptococcus species. So in all these organisms, please remember this beta glucon test is not useful for the diagnosis. But for cryptococcus, then what do we use? Okay, now let me just quickly recap this particular cryptococcosis. So what is the most common, this cryptococcosis, this is the most common cause of the fungal meningitis, right? Most common cause of the fungal meningitis. Now, what is the predisposing factor for your cryptococcosis? Number 1, the patient on chemotherapy for hematological malignancy. Patient on chemotherapy for hematological malignancy. Next, the other predisposing factor is Hodgkin's lymphoma. And the other important risk factor is the patient on steroid therapy and transplant recipients, because these transplant recipients, they will be on immunosuppressant drugs, and HIV infected individuals, and those individuals who are on TNF alpha therapy, right? TNF alpha inhibitor therapy. These are the predisposing factor for the development of cryptococcosis, right? And you will have all the signs of meningitis. What is that? Headache, abnormal mental status, and neck rigidity. You will have Brudzinski sign, and you also have Kernick sign. Then how do you diagnose this particular cryptococcosis? See, the diagnosis is by demonstration of capsular polysaccharide antigen. You have to do CSF analysis, in which you have to demonstrate capsular polysaccharide antigen or the positive culture in CSF. That is how you will diagnose this cryptococcosis. Now you should know right? Then you should know what is the drug of choice for the cryptococcosis. Drug of choice for cryptococcosis is liposomal amphotericin B, right? Liposomal amphotericin B. What is the dosage of this liposomal amphotericin B? You should give 3 to 4 milligrams per kg per day, right? You have to give intravenously. For how many days we give this? We give this for nearly around 14 days. That is the preferred agent for induction therapy, right? That is to start with. And what will be the consolidation therapy or continuation therapy? This is followed by, you have to give 8 weeks of the fluconazole, right? 8 weeks of the fluconazole, okay? And this fluconazole, the dosage is 400 milligrams per day. You have to give once daily, right? Per day, once daily. So this is about the story related to your cryptococcosis, okay? Now let me just quickly recap the topic related to this 1,3 beta glucon test. So this is useful for the diagnosis of the aspergillosis, candidiasis and PCP, but it is not useful for diagnosis of mucar, rhizopus, blastomyces and cryptococcus species. And if you take this cryptococcosis, the important points related to them are, this is the most common cause of fungal meningitis. Predisposing factor for cryptococcosis is chemotherapy for hematological malignancy, Hodgkin's lymphoma, patient who is on steroid therapy, transplant patients and HIV infected individuals, and TNF alpha inhibitor therapy, right? And they'll have the signs of meningitis, features related to meningitis. How will you diagnose? Demonstration of capsular polysaccharide antigen or positive culture in CSF is diagnostic. Drug of choice will be liposomal amphotericin B, 3 to 4 milligrams per kg per day intravenously for 14 days. That will be the induction therapy. Followed by that, you have to give additional 8 weeks of fluconazole, 400 milligrams per day orally. That is consolidation therapy. So that is about your cryptococcosis, right? Next, then, right, you see the next question. A 12-year-old patient presents with fever for 3 days. You have clinical suspicion of dengue and have to investigate him. Which test will not be helpful? Which test will not be helpful at this point of time? So fever, how long? Fever for 3 days. Fever for 3 days. Right. So you take this particular dengue. So what is the mosquito that will transmit this particular dengue virus? So it is again the same mosquito, that is Aedes, right? What we were discussing at in the beginning of the session. Now, okay, so what is the correct answer in this particular question? The answer is D. Anti-IgM dengue antibody will not be helpful at this point. Now, let me explain to you about the serology of the dengue. Let me explain to you the serology of the dengue virus. You take RT-PCR. RT-PCR nucleic acid detection that can be done within 1 to 5 days of onset of fever. NS1 antigen you will have within 1 to 6 days of onset of fever, okay? Whereas you take IgM ELISA, IgM ELISA will be positive after 5th day of infection, whereas IgG ELISA, that will be positive after 15 days of the onset of symptom, right? After 15 days of the onset of symptoms, okay? So that is about the IgG. So this serology is very, very important for you in your exam, right? And to quickly tell you about the dengue, right? Some quick points about the dengue. So what is the incubation period for dengue? The incubation period for dengue is 7 to 10 days. What will be the clinical feature in these patients? They will have a very high grade fever that will be associated with chills and rigors. Now, along with that, they will also have myalgia, severe muscle pain. There will be also arthralgia. Followed by that, they will also have headache. Very, very important point is retroorbital pain. right? Retroorbital pain. Now, when will you call severe dengue? We use the term severe dengue whenever there is plasma leakage and whenever there is hemorrhage, right? Or whenever there is the organ involvement, right? Whenever there is organ involvement, then we use the word severe dengue. Now, what are the signs of hemorrhage? The signs of hemorrhage will be ecchymosis. Signs of hemorrhage will be gastrointestinal bleeding. Signs of hemorrhage will be epistaxis that will appear later in the disease. Now, you should know what are the complications that you will come across in these patients with the dengue. So, dengue complications, bone marrow failure can be there. Bone marrow failure, and there can be also development of pneumonia, and there can be also development of the hepatitis. So these are the complications that you will come across in dengue. And not only that, the orchitis, whereas in females, the euphoritis. The neurological complications in dengue, they are very rare. But what are those? The neurological complications will be in the form of the Guillain-Barré syndrome. There can be development of subdural hematoma. There can be development of transverse myelitis, right? And there can be also phrenic neuropathy. Once there is phrenic neuropathy, then the individual will develop respiratory muscle paralysis. Respiratory muscle paralysis. Then what is the treatment that you will come across in dengue? So it is just only volume replacement. It is only volume replacement. That is very, very important. Then you should give blood products. What are these blood products? That is the platelets. That is the platelets. And then we give vasopressors, that is mainly to improve the blood pressure. And for fever, what do we give? For fever, we give the paracetamol or acetaminophen. So it is completely supportive treatment. It is only supportive treatment. Okay. So, and one important test in case of dengue. Now, can anyone tell me what is this particular test which is being done for dengue? What is another name for this tourniquet test? What is another name for this tourniquet test? So the another name for this particular tourniquet test, this is also called as the Hess test, right? This is also called as the Hess test. Okay. And what is the purpose of doing this Hess test? That is mainly to assess the capillary fragility. That is mainly to assess the capillary fragility. Now, how do you do this particular the Hess test? So to perform the test, the BP cuff is applied to the arm, and you need to inflate the BP cuff, and you have to maintain the pressure between systolic and diastolic blood pressure for nearly around 5 to 10 minutes. After removing the cuff, you need to count the number of petechiae. You need to count in the number of petechiae in 1 to 2 inch diameter circle, right? In 1 to 2 inch diameter circle, you need to count the number of petechiae. And when will you consider the test to be positive? When the number of petechiae, if it is more than 10 per 1 square inch, right? If the petechiae are more than 10 for more than 1 square inch, then your Hess test is considered to be positive. Okay, but you should know that the purpose of doing the Hess test is mainly to assess the capillary fragility, right? So to quickly revise about dengue, it is transmitted by the Aedes mosquito. Incubation period is 7 to 10 days. High grade fever, myalgia, arthralgia, headache, and retroorbital pain. When do you call severe dengue? Whenever there is presence of plasma leakage, hemorrhage, and organ involvement. What are the signs of hemorrhage? Ecchymosis, gastrointestinal bleeding, and as well as epistaxis. Complications include pneumonia, bone marrow failure. There can be orchitis and euphoritis. Neurological manifestation complications are rare, but that include Guillain-Barré syndrome, phrenic neuropathy, subdural hematoma, and transverse myelitis. Treatment is only supportive treatment, volume replacement, blood products, and vasopressors. And for fever, we give the acetaminophen. Right now, yes. Now, this is a very, very important question related to the same dengue. Cortex user, it is not more than 20, it is more than 10. Right, more than 10. Okay, now Agastya Gopi is asking about the platelet cutoff. So, if the platelet count is less than 10,000, then less than 10,000 and there is no bleeding manifestation, then you give platelets. Okay, then you give platelets. Okay, less than 10,000 and there is no bleeding. Now whatever might be the platelet count, if there is bleeding manifestation, then you need to give platelet transfusion. Yes, Agastya Gopi, is this clear for you now? So if platelet count is less than 10,000 and no bleeding tendency, then you give platelets. But if whatever might be the platelet count, if there is bleeding tendencies, then you have to give the platelet transfusion, right? Now, the most important parameter to monitor the dengue hemorrhagic fever is, right? Very good. That is the hematocrit. So for monitoring the patients of severe dengue, hematocrit is performed. If the hematocrit is rising, that indicates that there is development of dengue shock syndrome, right? It indicates that there is development of dengue shock syndrome. So hematocrit values can be used to monitor the fluid resuscitation in patients with the dengue. So it is also useful for assessment of the fluid resuscitation. So that is about your dengue story in a short way. Now, the discussion will not be over without discussing the tuberculosis. The discussion will not be over without discussing tuberculosis. A 26-year-old presents with history suggestive of tuberculosis. On examination, he has pleural effusion. All of the following parameters will be used for analysis of the pleural fluid except any one of you? Very good, Kavya. So the answer is the globulin. Okay. So please remember, this particular tuberculosis will cause exudative type of pleural effusion, and in this exudative type of pleural fluid, gene expert is considered as the investigation of choice. Lactate dehydrogenase levels are elevated, and this will be the part of your lights criteria, and ADA levels are also elevated in patients with the pleural effusion. See, now this ADA levels, how much it should be? So it should be more than 45 international units to consider it as the tuberculous pleural effusion. Now, why the ADA levels are elevated in patients with the tuberculosis? See, the tuberculous organism will stimulate the T lymphocytes. Right, will stimulate the T lymphocytes. So that stimulated T lymphocytes will be producing the ADA, and that is the reason why the ADA levels are elevated in patients with the tuberculosis. Now, in tuberculosis, everything you are very much aware of tuberculosis. Investigation of choice is your gene expert. Now, does anyone know what are the new drugs for tuberculosis? What are the new drugs for tuberculosis? Any one of you, please? What are the new drugs for tuberculosis? So the new drugs for tuberculosis, just make a note of it, that includes, right, very good. So that includes bedaquiline. Next, then the other one is dilamanid. One more drug is pretomanid. Right, the other drug is pretomanid. Okay, these are the new drugs for the tuberculosis infection. Now, some of you were asking, I think the Cortex user. So Cortex user was asking about the lights criteria. So what is this lights criteria is, so the pleural fluid protein, right, the pleural fluid protein, that should be more than 3 grams per deciliter. Then pleural fluid protein to serum protein, it should be more than 0.5, and the pleural fluid LDH and to that of serum LDH, this should be more than 0.6. Okay, this should be more than 0.6. So this is what are the points in your lights criteria. Okay, 3 are there. So out of 3, at least 1 should be positive. Right, out of these 3, at least 1 should be positive to consider the lights criteria is being positive. Okay, so yes, Cortex, did you understand this? Cortex user, and a student with name Cortex user. Have you understood this? Okay. Now, if you are done with this, then one more question related to tuberculosis. Okay. That is, you see this. All of the following patients should be tested for respiratory tuberculosis except HIV positive patients with persistent cough, diabetic patients with persistent cough, then known case of extrapulmonary tuberculosis with persistent cough, uh, contact with sputum positive patients of tuberculosis with persistent cough. The question is except. See, diabetic patients, see, both of these two, if you observe, right, both of these two, they are immunocompromised state. So whenever a person is like immunocompromised, there is high chance of tuberculosis. So patient having persistent cough in an immunocompromised state, definitely you should think of tuberculosis. Okay. And contact with sputum positive patient of tuberculosis with persistent cough, that is definitive diagnosis, but definitely tells that the individual might be suffering with tuberculosis. But the point which is incorrect here, known case of extrapulmonary tuberculosis, right? Known case of extrapulmonary tuberculosis. So what may be this extrapulmonary tuberculosis? See, extrapulmonary tuberculosis is defined as microbiologically confirmed case of tuberculosis involving lymph nodes, involving gastrointestinal tract, that is intestines, involving genitourinary tracts, involving meninges. Okay, so this will be your extrapulmonary tuberculosis. Okay, screening in case of extrapulmonary tuberculosis with persistent cough, we cannot suspect to be having the pulmonary tuberculosis. Okay, which group of patients you need to consider that the patient might be having pulmonary tuberculosis? Contact with a case of TB with microbiological confirmation, people with HIV, diabetics, immunocompromised patients, malnourished, steroids. So all these three, all these, they are like immunocompromised states. So if these patients are having persistent cough, definitely you need to consider the pulmonary tuberculosis. But extrapulmonary tuberculosis with persistent cough, that is not required to be considered as the pulmonary tuberculosis. Okay, right. So what is the investigation of choice for tuberculosis we have discussed? That is gene expert. Okay, which is nothing but CBNAT, cartridge based nucleic acid amplification test. And what are the new drugs? Just now you people have said, that is delamanid, bedaquiline, and as well as the one more drug is pretomanid. One more drug is pretomanid. Okay, right. One more question about tuberculosis, then we will move on to the next topic. Which one of the following is most likely to be associated with this image? Fever, weight loss, night sweats, and elevated ESR. Community acquired infections with rusty sputum and gram-positive diplococci. Acute dyspnea, elevated JVP. History of long air travel. Acute dyspnea, pink frothy sputum, mid-diastolic rumble at the apex. So, if you observe this chest CT, can anyone tell me what is the diagnosis of this chest CT? What is the diagnosis of this particular chest CT? What is this patient having? Yes. Okay. Very good, reformer. So the patient is having mild bronchiectasis. Okay. And that too, if you observe this particular area, what form of bronchiectasis is this patient having? So the patient is having this classical scattered tree in bud appearance, right? Scattered tree in bud appearance. So in which group of individual you have this bronchiectasis in the form of tree in bud appearance? You get this in case of pulmonary tuberculosis. So the answer to this question is the pulmonary tuberculosis, because the picture is suggestive of bronchiectasis of tree in bud pattern, that is suggestive of the pulmonary tuberculosis. So fever, weight loss, night sweats, and elevated ESR, like this is suggestive of your tuberculosis, and that will be the correct answer. What about the second option? Community acquired infection with rusty sputum and gram positive diplococci. So where do you get this? This will be your strep pneumonia. Okay, so in strep pneumonia, what will you get? You will not have this bronchiectatic picture. You will have lobar pneumonia in case of streptococcus pneumonia, right? So I'll just show you that CT of the lobar pneumonia as well. Okay, so this will be the CT image of the lobar pneumonia. So you can see that here it is the entire lobe which is being consolidated. The entire lobe which is being consolidated. That is how you will get in case of the streptococcus pneumonia, which is nothing but your pneumococcal pneumonia. Then what about the other options? So the other options like acute dyspnea, elevated JVP, and history of long air travel. What is this suggestive of? This is suggestive of pulmonary embolism. This is suggestive of pulmonary embolism. But what is the predisposing factor for the development of pulmonary embolism here? That is long air travel causing deep vein thrombosis, and that can shower an emboli. Then what about the fourth option? That is acute dyspnea, pink frothy sputum, and mid-diastolic murmur. So this patient has developed acute pulmonary edema. Now, what is the cause of this acute pulmonary edema? Now, can anyone answer this? This particular acute pulmonary edema in this patient, it is secondary to mitral stenosis. So, how can you tell that it is mitral stenosis? Because there is mid-diastolic rumble which is being present at the apex. Mid-diastolic rumble which is being present at the apex. Okay, right. Klebsiella. Moti Choti. We have a student username with Moti Choti. So, in Klebsiella, what will be the color of the sputum? Any one of you? What will be the color of the sputum in Klebsiella? In Klebsiella, it is red currant jelly. Okay, right. So that is about your tuberculosis. So we are done with the important points related to tuberculosis. Now, the discussion of infectious diseases should not wind up without discussing malaria, right? So I'll do a quick recap of the entire malaria. Okay, a young male came with complaints of high-grade fever and malaise. His peripheral smear was prepared and is shown below. What is the diagnosis? Vivax, falciparum, babesiosis, Plasmodium, malaria. Right. Okay, so here the answer is very good. So it is the Plasmodium falciparum. It is the Plasmodium falciparum, right? Very good, Moti Choti. So whatever you are seeing, how can you, what are the points in favor of your Plasmodium falciparum? You will have multiple rings inside the RBC, right? Multiple rings inside the RBC, and in some RBCs you also have chromatin dots which are being present. Okay, so these you can consider it as the chromatin dots, and these are the multiple rings, right? These are the multiple rings which are present within the RBC. So this tells you that it is your Plasmodium falciparum. Then what about the others? You take Plasmodium vivax. So how will you rule out this Plasmodium vivax? In case of Plasmodium vivax, please remember the infected RBCs, they are very larger. Right, the infected RBCs, they are very larger and may show an amoeboid trophocyte with Schaffner dots. Okay, so what are these dots here? These are nothing but amoeboid trophocytes with Schaffner dots. So that is what you will have in case of the Plasmodium vivax, right? Then now let me just quickly recap about this malaria. So what is the mosquito that will be transmitting this particular malaria? That is female Anopheles mosquito. Female Anopheles mosquito, right? And what will be the clinical features? That is the fever. High grade fever associated with chills and rigors. High grade fever associated with chills and rigors, and they also have headache. And on examination, if you observe, there will be splenomegaly because there is hemolytic anemia. So there will be pallor, and because of splenomegaly, there will be also thrombocytopenia, right? Thrombocytopenia. Then what is the best investigation? What is the mainstay of diagnosis? Mainstay of diagnosis is peripheral smear preparation. Peripheral smear preparation, that is either thick or thin blood smears have to be prepared. Now the point is, what are the stains we use? So the stains what we use for malaria is Giemsa stained blood smear, and the another alternative stain is the right stain, right? The other stain is the right stain, but which is more preferably used, that is the Giemsa stain. What is very important part of the discussion related to malaria is about the Plasmodium falciparum malaria. So complications of Plasmodium falciparum will be the cerebral malaria, right? There can be severe anemia, right? There can be development of the hypotension. Next, there will be development of pulmonary edema. Next, acute kidney injury. Then there will be also hypoglycemia. There will be development of acidosis, and there will be also hemolysis. Right, there will be also hemolysis. Okay, so which is not, and because of this hemolysis, like you get what is called as this black water fever. Okay, but what is the investigation of choice? The investigation of choice will be peripheral smear preparation. Actually, we have some rapid tests also, right? So we have rapid dipstick tests. But if you take this rapid dipstick test, now this rapid dipstick test can miss the diagnosis of certain plasmodial parasites. What is that? See, in this rapid diagnostic test, like what is the antigen that you will have? So the antigen that you will have is HRP2, that is histidine rich protein 2, right? And this rapid diagnostic test can miss the diagnosis of Plasmodium falciparum. So that is the reason why they are not considered to be the investigation of choice, right? Then what is the drug of choice for your malaria? So if you take the drug of choice for malaria, see, the first line drug for non-plasmodium, non-falciparum malaria, in most of the areas, it remains chloroquine. But the problem with the chloroquine is that the organisms have developed resistance with this, the chloroquine. So that is the reason why what are we giving now? What are we giving is ACT, that is artemisinin based combination therapies. What are we giving? We are giving artemisinin based combination therapies. Okay, that is for Plasmodium vivax. But for Plasmodium ovale, right? Plasmodium ovale or vivax, along with, if you are giving chloroquine, along with chloroquine, what should be added? Please remember, you need to add primaquine, right? You need to add primaquine, or the other drug is tafenoquine, right? The other drug is tafenoquine. Okay, so these are the drugs which need to be added. Then what about the falciparum malaria? Right, what about the falciparum malaria? What is the first line drug for the falciparum malaria? Yes, can anyone answer this? See, whatever the treatment what we have discussed is non-falciparum. What about the falciparum now? Yes. Yes, so please remember, for the falciparum malaria, the drug what we give is artesunate and as well as the mefloquine, right? Artesunate and as well as mefloquine. So please make this note. So first line therapy in the parts of Southeast Asia will be artesunate and mefloquine combination. But whereas in United States, if you observe, the combination that is being used is artemether lumefantrine. That is in the United States. But in India, that will be artesunate and as well as the mefloquine. artesunate and as well as mefloquine. So this is about the story related to malaria. So regarding malaria, let me just quickly recap related to malaria. So malaria being transmitted by the bite of infected female Anopheline mosquitoes. The clinical manifestation will be high grade fever with chills and rigors and profuse sweating. There will be also headache and vomiting. On examination, there will be splenomegaly, pallor will be there, and investigations there will be thrombocytopenia. But what is the mainstay of diagnosis? It is by your thick or thin blood smear, right? And the stains what we use is GMSA stain and as well as right stain, but the preferable stain is the GMSA stain. Regarding falciparum, the complications are cerebral malaria, severe anemia, hypotension, pulmonary edema, acute kidney injury, hypoglycemia, acidosis and hemolysis. And we also have rapid diagnostic test, that is the dipstick test. And what is the antigen that they use in the rapid diagnostic test? That is histidine rich protein 2. But by doing this dipstick test, we can miss the diagnosis of falciparum malaria. And non-falciparum malaria, the drug of choice will be chloroquine. But because of increasing resistance, the alternative therapy will be artemisinin-based combination therapies. And whenever you are giving chloroquine, along with chloroquine, you should combine primaquine or tefenoquine. And falciparum malaria in India, the drug of choice will be artesunate and as well as the mefloquine. So this is about the quick recap related to the malaria, right? Next, one more organism if you take here. Okay, a 26-year-old male presents with fever and headache for 3 days, right? Headache for 3 days. On the third day of illness, the blood pressure is 90/60 and examination reveals rash which is given on the legs as shown. What is the likely diagnosis in this patient? What is the likely diagnosis in this patient? Right, so okay, so I will tell you the correct answer and I will rule out the other options as well. So the correct answer here is the meningococcus. The correct answer here is meningococcus, which is nothing but your Neisseria meningitidis. Now, what are the points in favor of the meningococcus? See, now in case of meningococcus, the history will be a very short history, and that too in severe form of meningococcus, which we call it as fulminant meningococcemia. The history will be a very short history and the presentation will be high grade fever and they may go immediately into a state of sepsis, right? Immediately they may go into a state of sepsis, and you take that particular rash or you take that skin manifestation, right? So if you observe the skin manifestation, what is the shape of this skin manifestation? You have that stellate purpura, which is nothing but starry appearance. Okay, which is nothing but the stellate purpura. Stellate purpura with central dusky or gray hue. This is what is suggestive of meningococcal infection rash. So this will be gray in color, slightly gray hue will be there. That is a classical presentation in case of the meningococcemia, which is nothing but your Neisseria meningitidis, right? Now, Neisseria meningitidis as such is a very, very important topic. Now, let me just give you a quick recap of this meningococcus meningitis. So, you will have all the features of meningitis. What will be that all the features of meningitis? Fever, headache, and vomiting, delirium, convulsions. And on examination, you have this rash, and the rash will be stellate shaped rash with central gray hue. And this petechial rash, it is present over the skin and the mucous membrane. Present over the skin and mucous membrane. Okay, and you also have that neck rigidity will be there, Kernick sign will be positive, and Brudzinski sign will be positive. Then, what is the investigation of choice? So, you have to do the CSF analysis, right? So, when you do the CSF analysis, like what will be the color of the fluid will be, there will be a purulent spinal fluid. And when you examine, you will have gram-negative intracellular and extracellular diplococci, right? Gram-negative intracellular and extracellular diplococci, right? And what is the complication in case of meningococcal meningitis? That will be disseminated intravascular coagulation. Then what is the drug of choice? See, the drug of choice, please remember, it is aqueous penicillin G. Aqueous penicillin G, that is the antibiotic of choice, right? The route will be intravenous route. Okay, and what is the dosage? What is the dosage? The dosage is 24 million units per 24 hours, and you have to give this in 4 divided doses. Now, many of you are answering ceftriaxone. Ceftriaxone, when the aqueous penicillin is not available, the alternative drug will be ceftriaxone. But in the options, if you have aqueous penicillin G and also you have ceftriaxone, then the correct answer will be aqueous penicillin G, but it is not your ceftriaxone. So please remember, this is a very important point. Okay, so this question makes me to quickly recap about the Neisseria meningitis, which is also called meningococcal meningitis, and I will also try to rule out the other options. I will also try to rule out the other options. You take this dengue hemorrhagic fever. What are the points against the dengue hemorrhagic fever? See, in case of dengue hemorrhagic fever, the pattern of fever, what will be the pattern of fever? It will be biphasic fever curve will be there. Biphasic fever curve will be there. Okay, so, and along with fever, what will be the manifestations in case of dengue hemorrhagic fever? There can be severe and generalized headache, retroorbital pain, myalgia, arthralgia involving the knees and shoulders, rash, hemorrhagic manifestation, leukopenia. All that should be there in case of the dengue hemorrhagic fever, which is not given in this question. So your dengue hemorrhagic fever is ruled out. Then what about the other options? So if you take the enteric fever, in case of enteric fever, like what will be the characteristic pattern of the fever? In patients with enteric fever, it will be step ladder pattern of fever. Step ladder pattern of fever. That means every day the intensity of the fever will be gradually increasing, and the enteric fever is ruled out due to absence of hepatomegaly. Hepatomegaly is also a very important point in case of the enteric fever. So your step ladder pattern is not there and your hepatomegaly is also not there. So enteric fever is completely ruled out. Then why scrub typhus is ruled out? Scrub typhus is ruled out due to absence of eschar. See, I have shown you the first question about the eschar. Eschar is a classical manifestation in patients with the scrub typhus. So this is not there. So your scrub typhus is being ruled out. Okay. So now let me quickly recap about the meningococcal meningitis. So the presentation will be in the form of fever, headache, vomiting, delirium and convulsions. On examination, you will have petechial rash on the skin and mucous membrane, and you will have all the signs of meningitis: neck stiffness, Kernig sign and Brudzinski's sign. But what is the investigation of choice? Whenever you take the CSF fluid, it will be purulent, and you will observe gram-negative intracellular and extracellular diplococci. So it is the CSF analysis that will confirm the diagnosis. Okay, that is culture. And the complication will be disseminated intravascular coagulation. Drug of choice will be the aqueous penicillin G. Drug of choice will be aqueous penicillin G. And alternative drug will be ceftriaxone. Right? Alternative drug will be ceftriaxone. Okay. Now, answer this question. Last question. All are true about the whipworm except worms mature in jejunal mucosa, no pulmonary passage of larva, incubation period is 90 days, lemon-shaped eggs are there on stool examination. Yes. Right. So yes, anyone of you? Right. So the correct answer here is worms mature in jejunal mucosa is the incorrect statement. The question asked is except. The question asked is except. Now let me discuss about the whipworm. So what is the organism here? That is Trichuris trichura. Right, Trichuris trichura. Okay, so this is nothing but your whipworm. Now if you take the quick recap of this topic of this whipworm, the infections are acquired by ingestion of the ingestion of eggs containing the whipworm. And where do this larva hatch? The larva, they hatch in the small intestine and mature in the large bowel, right? Mature in the large bowel. That means within the cecum. That means within the cecum. Okay, right? So mature in large bowel to adult worms of about 4 centimeters in length. And these particular worms, they do not migrate through the tissues. So pulmonary involvement will not be there. And what will be the clinical manifestations? Most of these patients, they remain asymptomatic. But if there is heavy infections, these individuals, they can have the abdominal cramps. They can have the abdominal cramps. They can also have tenesmus, right, where the individual will have the sense of incomplete evacuation of feces. That is called tenesmus. Then the individual can also have diarrhea, nausea, and vomiting. So these are the features in case of heavy infections. And we have a syndrome called trichurous dysentery syndrome. Trichurous dysentery syndrome, this may develop particularly in malnourished patients. Okay, so mainly in case of malnourished young patients, you get this trichurous dysentery syndrome, right? So this particular trichurous dysentery syndrome, the findings will resemble inflammatory bowel disease, right? The symptoms, they resemble the inflammatory bowel disease, where there will be bloody diarrhea, right, where the individual can have bloody diarrhea, and the patient can also have rectal prolapse. The patient will also have rectal prolapse. Then what will be the shape of the eggs, right? So when you do a stool examination for this whipworm infection, the shape of the eggs will be the lemon shaped eggs, right? And what will be the dimension of this particular lemon shaped eggs, right? The dimension will be around 5 to 20 microns, right? 5 to 20 microns. So these are readily detected on the stool examination. But if you take the adult worm, if you observe, what will be the dimension of this adult worm? It is around 3 to 5 centimeters long, right? This is about 3 to 5 centimeters long. And these adult worms, occasionally you can see via proctoscope, right? You can see via proctoscope. Okay, these adult worms are located within the cecum and as well as the colonic mucosa. Then finally, what is the drug of choice for your trichuris trichura? So treatment is typically with albendazole, right? Treatment is typically with albendazole. So how much of albendazole we give? 400 milligrams per day, and you have to give this albendazole orally. What is the other drug, alternative drug? The alternative drug will be mebendazole, right? Mebendazole. Okay, these are the two important antibiotics. So the alternative, right? Alternative will be ivermectin. Right, alternative will be ivermectin. So that is about your trichuris trichura. So let me quickly recap about this particular trichuris trichura. So this is nothing but your whipworm. The infections are acquired by ingestion of the eggs. The larva, they hatch. Okay, so if you go back to the question now, go back to the question. Right, so the larva, they hatch in the small intestine and mature in the large bowel, that is within the cecum, not within the jejunal mucosa, right? Not within the jejunal mucosa. And the worms do not migrate, right? Do not migrate through tissues. Most of these patients are asymptomatic. If there is heavy infections, they may be accompanied by abdominal cramps, tenesmus, diarrhea, distension, nausea, and vomiting. And we have what is called trichurous dysentery syndrome that may develop particularly in malnourished young children, where there will be symptoms resembling inflammatory bowel disease, including bloody diarrhea and rectal prolapse. And how will you diagnose? By stool examination, where you will get the eggs of the trichurus. and it will be lemon shaped. The eggs will be lemon shaped eggs, right? Drug of choice will be albendazole or mebendazole. If you are giving albendazole 400 milligrams per day orally, you should give, and if you are giving mebendazole, you have to give 200 milligrams per day orally. And for how long you give? If it is light infection, the symptoms, if they are mild, 1 to 3 days you give. But if there is heavy infection where the individual is having like abdominal cramps, diarrhea and tenesmus, in such case you need to give this albendazole or mebendazole for 3 to 7 days, right? And alternative is ivermectin. Ivermectin, what is the dosage? 200 micrograms per kg orally once daily for 3 days you have to give. Okay, so this is about your trichuris trichura. So with this I'll wind up the today's session, right? So if you want this PDF, you can just join my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So in this channel I'll be posting this particular PDF. You can download this PDF with annotations directly from my Telegram channel. And tomorrow same time 9 p.m. we have the discussion on the dry topic of medicine, that is genetics, right? Dry topic of medicine, that is genetics. Okay, Karthik, okay, the egg what I have showed might not be lemon shaped. The egg what I have shown might not be the lemon shaped, but please remember the shape of the egg in case of trichuris, it will be lemon shaped eggs. Lemon shaped eggs. Okay, right. And yeah, Cortex user, I cannot post the link in the chat section because that automatically gets deleted. That is what is the thing that has been put from Unacademy. And if you are not able to get the link, okay, so you can just text me on my WhatsApp. This is my number, WhatsApp number, where I'll post you the link of my Telegram channel. I'll post you the link of my Telegram channel. You can text me on my WhatsApp. Okay. So with this, I'll wind up the today's session. So tomorrow I will discuss the genetics. Tomorrow I will discuss the genetics. Yes, Titan, what is your question, Titan? Acetyl. What is acetyl? Acetyl salicylic acid, you mean to say? Acetyl salicylic acid is aspirin. Right, acetyl salicylic acid is nothing but aspirin. Okay, right. So like these are some of the important infectious organisms that may appear in the upcoming NEET PG exam. So that is the reason why I have discussed whichever are very, very important, right? And in the upcoming sessions I'll try to discuss few more infectious diseases as well, right? So thank you very much, and see you tomorrow at 9 p.m. with the discussion of this very important topic, that is genetics. Okay, yes, Titan, very much thank you. And you take this Vipul Joshi, right? See, string test is being done for Vibrio. Yes, Vipul Joshi, this particular string test is being done for Vibrio species. For Vibrio species, we do the string test, right? So with this, let me wind up this particular session, right? So tomorrow we will discuss the